So I think at this point now, time-wise, I might just hand over to our chairs to introduce themselves and introduce our first speaker.
Good morning, everyone. I hope we can have a fantastic day today. I'm Nigel Mendoza. I'm a consultant neurosurgeon at Charing Cross.
Hi, I'm Surgeon Zach Verghese. I'm a consultant endocrinologist in Stevenage, East and North Herts.
Okay, starter for 10. I'd like to introduce our first speaker, who's Dr. Robert Morris, consultant endocrinologist from Leeds. He's going to talk about persistent low disease burden in acromegaly. What are our options?
Okay. Right, thank you for the invitation to talk at the meeting, Karen and Neve, and thank you to the chairs. So we'll kick off. Right, disclosures. Everyone seems to like me to put these down. I work with everybody who has anything to do with acromegaly by the look of it. Right, start with bits we know. So all of this, hopefully you know, first described acromegaly by Pierre Marie back in 1886. Acromegaly really is the clinical syndrome. It's not high growth hormone. It's a clinical syndrome produced by chronic exposure of the tissues to excess growth hormone IGF-1. Okay, it's of insidious onset and therefore the diagnosis delayed often for 8 to 10 years before we pick these individuals up. Classic somatic features, you all know, the big hands, the big feet, the classical changing of the facial features with the prognathism, the dental separation. And symptomatology-wise, again, heterogeneous and multi-symptoms. People with headaches, feel a bit tired, a bit more sweating. So nothing that usually, other than the somatic features, that really tells you this patient has a particular diagnosis, and hence why diagnosis is often delayed. Importantly, associated with an excess mortality, which we all know about, and significant complications, a whole list of complications, and we'll mention that a bit on the next slide. Prevalence-wise, probably somewhere about 100 cases on average per million, with an incidence of about 4 to 6 new cases per million of the population. And pretty much always it's due to a pituitary tumour. Literature say 1 to 2% GHRH secreting tumours, but a lot of the data comes from tertiary centres, which will have more of those kind of patients. So that's probably less. I think I only have one of those in a cohort of 183 patients with acromegaly, so it's not very common. And I think we wrote that one up as well because it was special. Aims of treatment. Once we've got a patient who's got acromegaly, what we want to do, primarily the patient wants you to make them feel better. So symptoms are the important thing, and their quality of life is what we need to get better. So those kind of things like fatigue, headaches, they would love to have smaller hands, etc. The sweating, the joint pains, the muscle weakness, all of that, the patient is what they want you to get better. Control of the tumour mass is second. Obviously, people who've got visual field deficits, it's really important we do that. And headaches may be linked to tumour mass in some patients, but not all. And then next, we're thinking about that mortality. That's something us endocrinologists have really got our teeth into. The mortality side is something we always think about when we're talking about acromegaly. And then the bit that's probably a little more forgotten about is that around treating the associated complications, and there's plenty of those, which we can either prevent happening, we can reverse in people who've got them, or if not reverse and improve them. And that includes diabetes, hypertension, sleep apnea, carpal tunnel, arthropathy, cardiomyopathy, hypopituitarism, chronic polyps or potentially colon cancer, vertebral fractures, impaired quality of life. So there's plenty of complications which I think get short shrift, unfortunately. How do we achieve our goals? Well, central to all our management patients with acromegaly is reducing that tumour bulk, particularly in patients who've got visual field deficits. And then we want to reduce that secretion of growth hormone and IGF-1. And if we can bring growth hormone and IGF-1 down, we improve symptoms, we improve the long-term complications, and we can normalize mortality rates. It's central to it, but it's not all. We need to think about replacing our pituitary hormone deficits. So that again will lead to improvements of symptoms. It'll prevent some of the complications of hypopit, like adrenal crisis. And hypopit itself is associated with increased mortality. So we have to think about that. And obviously will help us improve mortality. There's a bit of data around hypopit, having an increased SMR. The recent data published in the Lancet would suggest that that's been normalized, but it might not be all the replacement hormones. It might be that we've just got better at managing some of their comorbidities. And then there's the management of specific complications, which we don't need to forget about. So how do we do that? Our options, surgery. That's moved on now pretty much to endoscopic surgery. Radiotherapy, we had conformal 3-beam radiotherapy, which is what we all hear about. It's sort of moved on to IMRT now. Conformal 3-beam radiotherapy is not used very often now. IMRT is taken over, or VMAT has taken over. And then stereotactic, which we use a lot more for isolated pituitaries, as long as we've got a good focus and the tumour's not too big. And there's a bit of data emerging around proton being used in pituitary tumours. And I suspect, given the location of the pituitary, I think that literature will grow over the next few years as they seek to find things to do with the machinery in London and Manchester. And then medical therapy, we've got somatostatin receptor ligands. So you've got first generations, lenalidomide and octreotide, then we've got our second generation, which has our pasireotides. We've got our dopaminergic analogues, but pretty much the only one that's used is cabergoline. People don't tend to use the others in acromegaly, probably because cabergoline is a bit more potent and it's where the data is. And then we've got pegvisomant is our growth hormone receptor antagonist, and not much else at the minute. Biochemical targets, what are we aiming for? This is the data which came from Ian Holdway's group. This is the New Zealand data. They got 208 patients in that. There was 72 deaths. The data date back from 1964 through to 2000. So you can see that's over 40 years. So a lot of this data is using older assays and patients who were treated with conformal radiotherapy, because 143 of those patients had radiotherapy, which we don't have anymore. So difficult to interpret it, but if we take it as it is here, growth from 1 down to less than 1 looks fantastic. There's a less than 2 even seems to have an increased mortality, less than 3, less than 5 here, above 5 here. So clearly getting our growth from 1 to less than 1 looks fantastic from the New Zealand data, and IGF-1s below, well, we're in normal range, look great as well. Now our current consensus underneath that little bar there.
Yeah, we can. If you click on more, there's a way you can hide
video panel, is it?
No, not video.
Oh,
No, the
that
other one
didn't work.
below that. Hide floating meeting controls. There.
Hey, look at that. So current consensus, biochemical targets less than 1 and a normal normal age-related IGF-1. So this is all the stuff we know, hopefully. There's our algorithm. This was from the 2014 Endocrine Society guidelines. It hasn't really changed. I think it's pretty much the same. You've got acromegaly. The majority of people go down this route, have transsphenoidal surgery. Those in remission, we just monitor. Those who don't go into remission, have persistent disease, go this way and onto medical therapy as second line. Those who are poor surgical candidates, or we don't think we can cure them because they've got cavernous sinus, we might do some surgical debulking in those latter group, but otherwise primary medical therapy down here. And then we've got the choice of somatostatin receptor ligands, which we've mentioned, which is the majority of cases, occasionally dopaminergics for mild disease, and pegvisomant where we're struggling a bit more. And of course, we should now have in there, obviously, pasireotide, which wasn't available at the time this was written in 2014, or not widely. If these don't work as single agents, we can move into this box, and then you can combine agents or move between agents until we can get patients under control. And then this little box to say radiation anytime you feel like it. If they've had surgery and they've not gone into remission, you can use radiotherapy at any stage, which all sort of makes sense. And we should be able to just about control everybody. If we look at just the pasireotide data we've got, we know from the publications there, if we get pegvisomant doses titrated up, we can control 98% plus of patients, even with that one drug, let alone combining it with other medications. So we should be able to control 100% of individuals in terms of the GH and IGF-1. So here's this lady. This is back to the Mentimeter for you. She's 73. She's got acromegaly. She had preoperatively a growth hormone of 11.3 mics, didn't suppress to an OGTT. Her IGF-1's 54.6. And then she had her surgery, reassessed at 6 months. Her growth hormone's now 1.6 and her IGF-1 is 32. She's got no residuum within the cellar that we can see, so no further surgical options. She's pretty much asymptomatic other than a bit of fatigue, nothing else we can draw out of her, and she's got no additional pituitary hormone deficits. So our first question, does this lady require further therapy aiming to bring specifically to lower her growth hormone and IGF-1?
So I just do a little Menti thing. I'll just get that off on the screen. There it is.
Lovely.
There we go.
And off we go.
Oh, let's just hide that. There's definitely one yes and one no. So.
We'll give you all a couple of minutes to at home and here to. We'll give you all a couple of. Yeah. We'll give you all a couple of minutes just to be brave and vote.
Go back to the question.
So she's had surgery, not hyperpit, no symptoms. She's got a growth hormone of 1.6, IGF-1 was 32, I think. Normal was up to 29, so 234.
I'll just put that up again, and then you can see.
Good. Okay, shall we move on from that one?
Okay.
What did we decide?
We're just gonna. Oh, sorry, Corinne. What I wanted. That's what I wanted.
There it is. There it is.
Okay.
1 yes.
2 to 1.
2
on
to
the
1.
yeses.
And then let me get you just back to. There you go.
And then we'll just move on from that one because we've got another little question for you. We're moving on. So
You can read. You can.
If you go back to Menti, I'm sorry about this up and down nonsense, but
So next, what we're going to use, if we're thinking this lady does need further interventions, what do we think would be the intervention we would use? Okay, are we there?
I'll just see how many people have voted. Sorry, 10 seconds. So just a reminder, if you haven't voted, have a go. Options are radiotherapy, first generation somatostatin analog, second generation somatostatin analog number 3, cabergoline for number 4, or pegvisomant for number 5. So have a go the next 30 seconds or so, and then we'll have a look. Sorry, I meant to hide that now, otherwise it's a surprise. Hang on. Oh.
It's too late, it's too late.
All right. All right.
Right, we had a good number of responses there, didn't we?
Let's have a look.
88.
Yeah. Pretty good. So we're mainly thinking first generation somatostatin analogs and cabergoline, aren't we? And a few on the other modalities that we've got. Okay. Put that down. So off we go. So let's start by thinking next, if we move on, how effective are we at the minute at achieving our biochemical targets? Well, if you look at the UK acromegaly database, they published some data around patients on medical therapy, aiming for a growth hormone of less than 2. Only 75% of people achieve that. So we're not doing great. If you look at those that have got a growth hormone less than 2 and a normal IGF-1, it's no more than 55% on first generation analogs and no better than 36% in patients receiving cabergoline. So we're not doing brilliantly, is the bottom line. So there's a good amount of people who are not controlled. If we look at next, GH-IGF-1 discordance, so people who've got either high growth hormones but normal IGF-1s or normal IGF-1s but low growth hormones, there's a meta-analysis that was published looking at over 7,000 cases of treated acromegaly. 25% of those showed discordance still. So these are people whose numbers are not hitting targets. Either their growth hormone is still too high or their IGF-1 is still too high. So there's 1 in 4 individuals there who on this data would suggest we're not controlling them to our target level. But they probably all got fairly mild disease. And would that fit in with what we know? Here we go, first line transsphenoidal surgery. It achieves remission in about 90% of microadenomas and about 40 to 50% in the good centers with surgery. If you've got cavernous sinus invasion, then you're probably only hitting 20 to 30% cure rates. So you end up with only about 40 to 65% biochemical remission, depending on which literature you believe, but it's in that range, which means we've still got 35 to 60% of patients after surgery who have got active disease. If we then throw in our first generation somatostatin analogues, they will normalize IGF-1 and growth hormone, if you want both numbers, in probably 35 to 40% of the individuals that are in this cohort. So you've still got left 26% of patients, despite surgery and somatostatin analogues, who have active disease. But because we debulk them, because we give them the somatostatin analogues, it's probably mild disease. So 1 in 4, we think, approximately, probably requires a bit more intervention. But I suppose the question is, do we need to treat them all? And we'll call that low disease burden. There's no definition for what we think of as low disease burden, but I suppose we can define it biochemically, and I've sort of made up some numbers. So growth hormone less than 2.5 or an IGF-1 less than 1.5 times the upper limit of normal. But I've completely made those up, so there's not any consensus on it. This is just to give us an idea of the kind of patients we might be thinking about of what to do with. And I'm not sure we know the outcome of these patients. So we have big cohorts based on patients which are a mixed cohort. We have those that are in the cured range, but we don't have otherwise stratified data. If we take the data we showed you from New Zealand earlier, they only had 78 deaths and they had 5 lines. So the most you'd expect, each line's only got about 18 patients in it who have died at most. So the numbers we're basing on all this are pretty small. So to figure out a group that's got those kind of numbers between 2.5 and 1 is going to be difficult unless we have big multi-center studies. So I'm not sure we know the outcome of these individuals. I'm not sure that we know what the impact of lowering their growth hormone IGF-1 is, or if we make them any better, and whether they actually do need specific treatment. And that's what I think we're going to explore a little. Let's see what we can deduce from the available data. So we know, first of all, if they've got a tumor mass and it's causing visual field deficits, we're going to operate on them and we're going to reduce that, or we're going to treat it somehow. So those patients we can forget from the start. So we don't need to think about tumor mass because we know we're going to treat those. So the other things we need to think about: patient symptoms, complications, mortality. Quality of life. This is something we did in Leeds. There's only 28 patients in this. They've got controlled disease in the old days when the growth hormone we used to aim for was 2.5 before the 2014 consensus. And then we followed them up. They had a growth hormone to start with at 1.6. We've made it better and it's dropped to 0.7. So their growth hormones are now beautifully controlled. Their IGF-1s haven't really changed. Top end of normal, but just about there. And if we look at the overall scores from the acroqual, so this is a specific quality of life score for acromegaly, PGWB and this SF36 are generic scores. They haven't really changed over that time period. So we've lowered their growth hormone from not controlled patient to now a controlled patient. Their quality of life on the acroqual, no different on the PGWB, and on the SF36, they're actually more miserable despite us making their biochemistry better. PGWB, what's a normal value? They've got a value there about 66. Untreated growth hormone deficiency, if you pick the miserable people, it's about 60 on our data. And normal people is somewhere about 80 to 85. So these people are not happy. Total scores, we can say SF36 has gone down. Why has that gone down? It's pretty much here, physical functioning. So this is clearly, the big hands are still problematic to them. They get an arthropathy, which we'll talk about in a minute. So that side of things, they can do less. This is a 5-year period, so that's probably why it's got. We don't have data more acutely. And energy and fatigue, one of the things they complain about. We've not made that any better. We've made their growth hormones better, but their fatigue is no better. So from a patient perspective, their health-related quality of life, If we look at it in all studies, it's impaired in all studies. That's a consistent finding. You need to differentiate between quality of life and symptom scores when you really read the data. Symptom scores all improve, quality of life not necessarily as marked. There's a poor correlation between quality of life and the GH and IGF-1. And even if we treat people well, we rarely normalize their quality of life. So that suggestions there is our quality of life of these patients. It may not be completely determined by the GH and IGF-1 status, which is what we all as endocrinologists focus on. So we need to think differently. Arthropathy. Commonest complication of acromegaly, 77% of patients on clinical criteria or complaints from the patients. Radiographically, it's everybody. It's a non-inflammatory arthropathy. When you, in the early stages, you get enlargement of the cartilage and thickening as it wears on the cartilage. Wears away, it becomes very, very similar in the later stages to osteoarthritis. It affects all joints. It affects the axial skeleton, it affects the appendicular skeleton, both small joints and large joints. Main symptom is pain, but also stiffness, so very similar to OA. It can progress to debilitating pathology similar to OA, and about 3 to 10% of patients with acromegaly end up with joint replacements, for a fair amount. The progression occurs even if you push these people into remission. Doesn't make any difference. They still get worse. All your patients with beautiful numbers, their arthropathy is going to get worse. You can't stop it. The biggest determinant is probably pre-treatment IGF-1. So the damage to the joints is done before we diagnose these people. The way to make this better and prevent it is diagnose people earlier. We're not going to do it by tightening up the growth hormone and IGF-1. And age, we can't do much about that one either, unfortunately. Headaches. 70% of patients with acromegaly have headaches at presentation. We're not sure why. If you compare similar sized tumors of non-functioning adenomas to acromegalics, there's a lot more headaches in the acromegalics than there is in a similar sized non-functioning tumor. So it's not tumor size. People have measured intracellular pressure to see if that correlates with headaches. The data is a bit soft. Again, not convinced. Is it a nociceptive peptide that growth hormone is secreting? Possibly. Tumors are secreting? Possibly. Or is it growth hormone that's an irritant? Possibly. But they seem the more likely of the two. It is helped by control of tumors and IGF-1, and most patients see improvements in their headaches once we debulk their tumors and we bring their numbers down. But there is a small portion, and I don't know how big that proportion is, who have severe headaches. And there's no relation in these patients to growth hormone status, and they occur often in patients who have good control of their IGF-1 and growth hormone. They're poorly responsive to analgesics, but they respond really well to subcutaneous octreotide if you give it small doses regularly. I have one lady who does that and is injecting herself. She's managed to get it down to 5 times per day, but she's got beautifully controlled acromegaly, and we're giving her long-acting somatostatin analogs as well, so she can reduce the amount of subcut stuff she uses, even though she had great control anyway. But it works well, which would again suggest it might be some kind of peptide that these tumors are secreting. Hypertension and diabetes, less data on this. Hypertension, it's 30 to 40% of diagnosis, but if you use 24-hour ambulatory monitoring, it's probably nearer 20 to 25%. If you reduce IGF and growth hormone, then the blood pressure gets better. And probably if we've got controlled patients, it's pretty much back to normal and equivalent to what the background population is. If we've got people with mild IGF-1 and growth hormone levels, there's no data. Diabetes, again, very, very common in acromegaly. 16 to 56% of patients with up to 45% also having impaired glucose tolerance. We treat them and bring their growth hormone and IGF back to normal at their surgery, and we resolve that in 23 to 58% of cases. But despite doing that, the prevalence of diabetes is still higher in the population of cured acromegalics than it is in the background population. So we don't reverse all the diabetes despite putting things back to normal with their growth hormone excess. And that probably means, again, the damage is done. It's a bit like trying to reverse type 2 diabetes, isn't it? You can do it with extreme weight loss, but otherwise it's quite difficult to reverse once it's there. And usually comes back again, even those people who lose lots of weight. Sleep apnea, another one of our side effect complications. So they get macroglossia. There's the increase in the soft tissues, which are being produced because of that. And if you look at acromegalic patients, once we've got their IGF-1 and their growth hormone back to normal, you can still tell they had acromegaly. They don't look normal still. The features are still there. So the soft tissues, despite control of growth hormone IGF-1, don't go back to normal completely. So you therefore imagine the same would happen in the larynx and the pharynx. Why would they go back to normal if the rest of the soft tissues don't? So it's reported in up to 88% of patients. They've got, it doesn't seem to be a direct effect of growth hormone IGF-1. It doesn't correlate to IGF-1 and growth hormone very well. So your AHI, your apnea, hyperapnea index doesn't correlate with these values. We know sleep apnea has a lot of problems, including lethargy and all the cardiovascular negatives to it. So important that we manage it. It does improve with growth hormone IGF-1 control, but it's not predictable. We see improvement in 33 to 100% of cases with surgery and somatostatin receptor analogs. However, that's improvement rather than resolution. And we still end up, even in controlled disease, with 40% of patients having sleep apnea. Here's some data with somatostatin analogs. So these have been treated. The patients at the beginning are there. And we see with surgery, 14 of these 23 patients improved, 2 didn't change, and 17 got worse despite us controlling their growth hormone IGF-1s. So we're still left with a number of people with sleep apnea. The most predictive factor, even in acromegalics, is their weight. And we often see, once we control growth hormone IGF-1, that patients with acromegaly, their weight goes up a little bit. So that's one of the reasons that it might get worse, and why we might even develop some new cases of sleep apnea that weren't there before we treated them. Management here is, again, it's not going to be growth hormone and IGF-1 control. It's going to be weight loss. It's going to be CPAP in the moderate to severe, and optimizing the other pituitary hormones, because we know hypothyroidism and testosterone replacement can contribute to sleep apnea. The major concern we all have as endocrinologists is the mortality, though. We know it's there. The SMR, so the standardized mortality rate in studies on the meta-analysis before 2008, is 1.75. It is now in the post-2008 studies 1.35. So we've made big inroads into this. So the numbers of patients with controlled disease in those studies don't look to be greatly increased. But it doesn't appear to be just growth hormone control that's made a difference to this. There's probably a lot more to it. The excess mortality across the studies is usually quoted as vascular disease, respiratory disease, and malignancy. Be the 3 I'm sure you've all heard of. Caveat being what we mentioned already, this is data, a lot of it dates back more than 30 years. We've mentioned our growth hormone targets already. So the excess mortality, we'll go back to this in, again, this was the data I showed you earlier. Had an SMR, which fits with the data of 2004, it's before 2008, it's got SMR 1.7, fits in beautifully with what we know. What were the deaths due to? Cardiovascular disease, 50% of them, cerebrovascular 11. So the deaths, 61% of the deaths in this cohort are vascular. Malignancy, 17. It's 24% of deaths were due to malignancy, but it's below what was expected in the study. We haven't seen an increase in malignancy, and we've got 2 patients who've had respiratory disease. So we're thinking here is where most of our excess mortality is, in the cardiovascular. Steve Orm's work done across the UK from 15 tertiary pituitary centres, much bigger cohort here, 1,300 patients, a lot more in the deaths, but the FCMR in the UK, unfortunately, seems to be a lot worse than everybody else's. But again, cardiovascular disease here is, and cerebrovascular disease, we're talking vascular disease, it's 50% of the patients again. Malignancy was mildly up on the SMR, but it was not significant. It was well within the confidence intervals, and they said it was mainly colorectal, breast, and lung. There was 1 thyroid case in there on the incidence data, but nothing about it causing mortality. And why I mention that is because there's some data over the last 5-10 years saying all these patients should be screened for thyroid cancers, because 40% of them get thyroid cancer. None of them are dying from it. I'm not sure why we should be screening stuff that's not causing these patients any problems. Respiratory was increased in this study. It's probably one of the only studies that actually shown a significant increase in the mortality from respiratory disease. compared to the others. This is 24, similar to the British study, 24 Italian studies. I don't understand this. It's only got a mean follow-up of their patients of 120 months. I thought it would be longer, seeing it dates back a long time. But again, they've got death rate, again, it's about 40% from vascular disease, but they've seen a lot more malignancy. Again, lung, colorectal, and breast seems to be the same. The cohort is also odd because about 20% of patients, they also, of their deaths, didn't have a cause for, they weren't sure what they died from. And they only had 61 deaths, which compared to Steve Orm's work where he had 366 deaths, this is a bit odd. This is the lowest SMR in any published paper of acromegaly mortality. So either the Italians are doing something different and fantastic we need to learn from, or we've got some missing data here, including this. Esposito, the Swedish registry, 232 deaths in 1,000 patients, SMR gain quite high, vascular disease in 40%, malignancy 21. The malignancy rates in all of these studies has been about 20%. Some of them say, despite it being about 20 to 24%, that's higher than expected. Some say it's lower than expected, despite all being about 20%. Respiratory, not too bad. So from the mortality data, and this is the one I say that people are most concerned about, we've got excess deaths, but that seems to be reducing over the decades. I've shown you the SMR has been coming down. It's now only 1.35 on the meta-analysis, so that's looking good. It's multifactorial. We've improved the surgery. We've got better at treating hypopit. We're seeing less patients with hypopit. It's much less post-surgery. If you look at the early data from the studies pre-2008 to the ones later, the amount of patients with hypopit is much less. We're managing vascular risk. I think we've all learned these people have cardiovascular disease, and we're instituting hypertensive, controlling their diabetes, looking at their lipids, and we're surveilling better for complications, the cardiomyopathies, for example. So we've got 40 to 60% of the deaths are vascular, 20% is due to malignancy, but we're not sure. It's still contentious whether patients with acromegaly do have an increase in cancer risk. If they do, it's going to be colorectal, breast, and lung where we need to look at. And the breast is only increased in females. The excess deaths there from all these data would suggest that it's predominantly vascular. Okay, we've not really seen a lot of excess deaths from other things. So if we go back to our low burden disease now, as a summary, what we could do in these patients, if we've got robust control, if we take these patients like the one we described and we really control their IGF-1 well, we might not make any difference to their quality of life, as I've shown you. We didn't make any difference in Leeds. Maybe it's different in London, but we didn't make much difference. Headaches might not get better. Your tumor is already controlled. You've got a growth hormone that's already low, so we may not make your headaches better from the point of view of lowering the tumor bulk. But there's going to be a small amount of people that will respond to first generation somatostatin analogs, short acting, as their headaches. We're not going to make any difference to the arthropathy. It's going to progress whatever we do. Sleep apnea, if we haven't improved it by bringing their growth hormone down to 1 to 2-ish, to 2.5 mics, I suspect lowering it to 1 isn't going to make much of a difference. It'd be much better for them to lose 4 or 5 kilos. That would be much better use of our time. We're unlikely, if our growth hormone is already down to 1 to 2-ish, bringing it down further so that it doesn't have a natriuretic effect and push blood pressure up is unlikely to make much difference. And a lot of the people, carbohydrate handling, so diabetes, we're unlikely to make much better. Most of these individuals with mild disease burden have high IGF-1s and lower growth hormones. And IGF-1 actually tends to lower sugar rather than putting it up. The impact on mortality of lowering, it's unclear. I don't know the answer to that one. That's the one that would be interesting to know. If we do lower our growth hormones from 1.6 to 0.7, do we affect mortality? I'm not sure. But it's the cardiovascular mortality we'd be thinking of. And if we were to treat these people, we could treat them with drugs, but we're potentially going to give them adverse events. So if we give them first generation somatostatin analogs, our main problem is we're going to give them GI side effects. And there's patients out there who continue to have GI side effects. Unless you ask about it, the patients don't tell you. They've got so used to it. I've got patients who are on these drugs for 10 years. And I'd asked them recently, do you still have it? And they go, oh yeah, I've still got that. And they don't moan about it because they know it's part of their treatment. So I don't actually know how many of these people have problems with long-term GI side effects that don't get completely better. The patients tend to tolerate it. If we use the second generation somatostatin analogs, the studies would suggest that probably 40 to 60% of patients end up with diabetes, which in itself has increases your SMR. So we don't want to do that. So it's not a drug I use, and except for, well, I probably don't use it because I've moved to pegvisomant instead. The dopaminergics, all fine, but we'd have to think, are we going to use those dosages that are above 2 milligrams, in which case we've got to echo them every year. And we've got all the problems around impulse disorders and deciding if people have got impulse disorders or not. And if they're drug related is possibly the hardest to figure out. So it could give them other problems. Oh, 20% risk of gallstones as well with the somatostatin analogs. So in all of these patients, is there really a need to treat everybody who's got slightly increased IGF-1s and growth hormones? I don't know the answer to this. We could aim to normalize the biochemical markers and then potentially give them all the side effects of treatment. I'm not sure what we've been making better. Maybe their mortality. The rest of the data I've shown you, I'm not sure we'd improve much. Or we could just simply monitor their disease activity, manage any symptoms they've got, try and improve their fatigue, treat all their complications, so their sleep apnea, make sure that's appropriately treated, the diabetes, everything. And we can aggressively manage their vascular risk factors because we know that's where the mortality is. And if we manage that, that may be more effective than bringing down their growth hormone. So I suppose the final thought there, therefore, is management of morbidity and risk factors in patients. Is it an acceptable option just to watch these patients and monitor them? And I don't know the answer. So back to that lady, we all said, I don't know, we can go back and see on the Mentimeter and see if anyone's changed their mind or not. Maybe not.
I haven't put in a second one. Can you do that?
Okay, I'll do that. Just go back to that was really clear, very thought-provoking, I think. So I'll just duplicate this slide and we'll ask it again. Right, all, do you want to have another vote?
Our lady, remember, had a growth hormone of 1.6, IGF-1 of 32, normal being up to 29.
And she was 63.
73.
23.
Yeah,
I'll
she's
put it up
older.
He's older now. Aged 10 years and half an hour. Rob, whilst we're waiting, Rob, that was a fantastic talk and raised all sorts of questions. And we face this every week in our MDT, so I'm sure everyone else starts. I mean, as a surgeon, I always get a little bit concerned when faced with, say, a patient in their late 70s, early 80s, basically fit and well with acromegaly and being pushed towards surgical treatment. When you think, well, what am I really going to achieve here, given the potential risk of surgery? Do you have a feel for an age range where surgery might not be appropriate?
I don't know. I think people age differently, don't they? So once people get older, I think some people are really healthy when 80, and other people are fairly frail when they get to 80. So I think it's individual once people get older, isn't it?
I mean, the mortality data from Italy can be pretty much discounted because they're only over a 10-year period. It's quite clear you've got to follow these patients up for all their lives to see where the mortality rate then matches a normal population. And presumably in the future, with modern advances in endovascular techniques for treating ischemic stroke, and perhaps better methods of treating cardiovascular disease, be it hypertension or cardiomyopathy, that mortality will also go down.
Yeah, hopefully.
Are there any questions?
I've got some on the chat here. I'll just read it out here. There's first question here is, are there any head-to-head trials to compare the efficacy of pasireotide versus pegvisomant? The answer might be no. But...
So sorry, so this was I can't multitask like this. Sorry, so before you heard Rob's talk, we had 58% 58 people rather, saying that they wanted her to have further therapy, and 32 said it was about 2 to 1, didn't we? 32 didn't. And you've swayed
Yeah,
the
we moved it
room
the other way.
and online
Good.
tremendously. Sorry, why don't you read out that question
Yes.
again, actually?
So first question is about head-to-head trials comparing paclitaxel against pegvisomant. Are there any?
Not that I'm aware of. It would be difficult. A lot of these studies, when you compare therapies against other therapies, because you need so many patients to show subtle difference, because the difference between placebo and treatment is large, which is what all the phase 3 studies have done that. But when you treat two treatments which are very similar, then it's tougher to show improvement. So it's very rare you get head-to-head studies in any disease unless it's incredibly common.
Yes, thank you.
We've
that's
got
a good point.
time for one brief question if there's anyone in the room.
There's another one online.
One from the
Am
chat.
I allowed to ask a
Yes,
question?
of course.
Sorry. I'm going to say I'm Neve Martin from Imperial College. Okay, it's just so I really loved actually when you sort of show the reasons for mortality, and we spend a lot of time, reasonably so, doing the colonoscopies every 3 to 5 years, etc. But obviously that magnitude is around cardiovascular death, as you've pointed out, and I sort of sometimes wonder then what targets am I using for statins, because there doesn't seem to be anything that I can find about we've got very clear targets for type 2 diabetes or diabetes in general. So I use total cholesterol less than 4, LDL less than 2, because that's the only target I've got. But I'm sort of reaching for a statin because I sort of see not great lipids in someone like this, and I want to tighten up cardiovascular risk, but I don't actually know what targets I'm supposed to use. What do you use?
Again, I think that's pretty difficult because I'm less likely to treat people when they're younger, which might be wrong. Because you're thinking longevity of starting people on statins when they're 30. For 80 years, I worry a little bit more about where I'd be happier to start statins as people get older. And I suppose I'd be, I'm usually happy if I bring their total cholesterol below 5. But again, it'd be a devoid area of any evidence.
Yes, there's not much. I mean, I suppose for type 1 diabetes, it's over 40 or 10 years plus, isn't it? So I agree, I wouldn't want to put a young person on a statin either. But in the older patients, I don't really have a target. I just have to use the diabetes ones. I don't really know what else to use.
I think that's fair, isn't it?
Yeah.
Again, I don't think there's any evidence-free zone.
Yeah, thank you.
Whatever you want.
Thank you. Can you do the one on the chat?
There's one last thing in the chat, which is a comment, really, which is very helpful from Ryan DaCosta from Wakefield, who says, "Thanks for a great talk. It's difficult to tease out quality of life because of the heterogeneity of the complications, but it does show how difficult the interpretation of these data can be. Perhaps we should focus more on complication management rather than be too focused on the biochemistry."
Yes, agree completely. I think, Ryan, very sensible. We need to stop thinking so much about trying to get tight IGF-1 and GH control and think about all the other aspects of their care and how we can make them better.
Okay.
Thank you.
Thank you very much.
Thank you.
Thank you. So can we congratulate Dr. Murray on an excellent talk? Thank you. And invite our next speaker to come down. Dr. Nipun Lakshita De Silva is going to present a case which follows on really nicely from this case.
Good morning. Thank you for giving me the opportunity to discuss today. So moving from that excellent talk on acromegaly low disease burden, we will move on to this patient, and probably I think the task was made quite easy. So this is a patient whose history starts from 1999 when he was 20 years old, who presented with impaired vision in his left eye, with intermittent headache, symptoms of carpal tunnel, and also he has mentioned about change in the ring size and the jaw size. He has stopped gaining height from 18 years and completed the puberty. When he presented, he had a height of 187 centimeters with a BMI of almost 30, and perimetry has shown left temporal visual fields, and also examination has clearly shown the evidence of acromegaly. Biochemically, acromegaly was confirmed with an IGF-1 of 179 and nadir growth hormone in the OGTT, which was 20 micrograms per liter. His MRI pituitary has shown a large cellular and supracellular mass causing significant chiasmal compression, but there was no cavernous sinus invasion. Unfortunately, because this is quite long time ago, we do not have access to the original images. And he underwent transsphenoidal resection of his pituitary tumor, and the histology confirmed pituitary adenoma with growth hormone immunopositivity. Again, we do not have the Ki-67 index. This is the 6-month post-op MRI, which shows some residual pituitary tissue on the left side of the fossa, and his random growth hormone now has dropped from 20 to actually more than 20 in the random at the beginning, and now it's 12.8, and his IGF-1 has come down to 155. It has dropped, but clearly it's above the reference range for his age. So I would like to ask this question from the audience. What will you want to do next?
Right, let's find that. Okay, that's on the screen. Oops, let's hide that.
Right. So this 21 to 22-year-old male.
Do you want to have back to the sorry,
Sorry.
I'll just do that. And just keep it there if you like.
Sure, thank you. So,
Yeah, go on.
yeah, who underwent surgery for a massive pituitary tumor coming with acromegaly, and now he has some residual tissue on the left side on the edge, and the growth hormone, random growth hormone and IGF-1 both are above the reference range for his age. So what would you like to do now?
Okay.
Okay.
So the majority of people want to start, majority of people want to start lanreotide. Some people want to do further surgery. All people want to leave them alone. Some people want to do radiotherapy, and one person for cabergoline. Okay, thank you.
Okay, thank you. So what I would do is, I would tell what happened to him, the story, because this is now more than 20 years long story. Let me take you through this story and you would find the answer how he was managed actually. So as I told already, he was diagnosed with acromegaly in 1999. Then he underwent transsphenoidal resection. Few months later, he was found to have persistent growth hormone excess, as I mentioned already. So what he was offered was radical external beam radiotherapy. And at the same time, he was also started on cabergoline and lanreotide, expecting the radiotherapy to take time to work. So in about 2 years' time, when he was found to have secondary hypothyroidism and hypogonadism, and also there was still persistent growth hormone excess, in the sense growth hormone was 2.9 and his IGF-1 was 107, slightly above the reference range. So at this point, by this time, he was started on levothyroxine and testosterone. Subsequently, because he wanted fertility, he was offered gonadotropin treatment and continued cabergoline and lanreotide. Then his partner successfully conceived with two twins with the help of IVF. Then by this time, still he was running slightly high with a random growth hormone of about 2.4 and IGF-1 above the reference range. Because as you can see, because he's growing older now, the reference ranges are changing. Now his reference is slightly lower, so he's still high. It had been decided at this time that while continuing lanreotide and cabergoline to add pegvisomant, at that time it has taken quite a bit of time to secure funding. So in 2011, he was started on pegvisomant as well. So he was continuing all 3 medications. Then by this time, he also developed symptomatic gallstones. Then he developed seizures where he was managed at another hospital and added anti-epileptic medications. This complex story made his adherence to pegvisomant injections a bit difficult, and his growth hormone and IGF-1 has by this time come lower down. In fact, his random growth hormone is now less than 1, but IGF-1 is just at the margin. But because of all these complications, it was decided to stop pegvisomant and continue him on lanreotide and cabergoline. And he also underwent a cholecystectomy. A few years later, even after cholecystectomy, he developed gallstone pancreatitis. while continuing lanreotide and cabergoline, and his IGF-1 has been just below the upper margin, and clearly growth hormone is less than 1. So it was decided to put him on a trial of lanreotide and continue cabergoline alone, considering the pancreatitis and as well as his IGF-1 is now in the range. So in about 6 months' time, when he was reassessed, his IGF-1 was almost there, but as you can see now, his reference range has further, age-specific reference has further come down because now he's in another age group.
Yes.
So it was decided, and at the same time, he underwent testing for
Is
mutations.
that the only one on the?
Nothing was
only one?
positive. And it had been decided, okay, lanreotide would be restarted because he's now again clearly above the age-specific reference range as per the standard guidelines. Now, last December, again, when he came to us, he was asymptomatic, completely well. IGF-1 is 37.8, slightly high, and random growth hormone is clearly below 1. So as you can see, last few years, he was always running a random growth hormone less than 1, though the IGF-1 was at the upper margin. In fact, at one point, he has, as I was cross-checked with another laboratory, because there was a worry about over-reading in the assay with us. So it was also the same range. So then it was decided, okay, we will try another trial of lanreotide. So now he's 43 years with no symptoms of active acromegaly. He's having dyslipidemia, and he has undergone a colonoscopy 1 or 2 years ago, which showed 3 hyperplastic polyps which are removed. He does not have other comorbidities like diabetes, hypertension, joint disease, heart disease, or symptoms of obstructive sleep apnea. He has gained weight a bit more. Now he's BMI in 36 range. And he's now continuing cabergoline in addition to thyroxine and testosterone. As you can see, after stopping lanreotide, his growth IGF-1 slightly came up, but it has almost leveled off now. And his growth hormone day curve done recently shows a very nice mean growth hormone level of 0.21 microgram per liter. And this is his latest MRI. As you can see, we don't see any target tissue. And he is not having a ACTH deficiency. So I would like to ask one more last question from you. What will you want to do next?
Oh, sorry.
No, this is not the question. No, sorry. Probably it hasn't come up.
Go to the next question. Just go next. It's all right. Just do that. And then go H before. That's the wrong one, is it? Okay.
This is the previous question.
No, there's somebody else, isn't it?
Probably it's not there in the system. That's okay.
Okay, it's all right. I haven't got it. Okay. Right.
Okay, I think.
Will you tell us what you, yeah? We haven't got it. Do we, yeah, it's all right. We
That's-
type it in, or-
So, shall I move forward?
Hmm?
Yeah, I think something
It's
wrong.
all right, it's all right.
So, so yeah.
I should have got questions. I do understand
So with that, I will like to conclude with these questions to the audience. So what are the possible reasons for his discordance? He has almost last 10 years, he has been running normal, less than 1 random growth hormone with slightly high IGF-1. And are we going to call him having remission in acromegaly? And how would he approach his long-term management? Thank you.
Okay, thank you very much, Nathan. Do you want to stay? Do you want to stay? Yeah. Do we have any thoughts on this case from the audience or from the people online? Any questions for the team? Yes.
You have to say who you are and where you're from.
All right. I'm Ramesh Nayak, consultant neurosurgeon at Team Video. At one point he went for radiotherapy when there was a not recurrent, residual tumor. Would it have been better to consider re-debulking and then radiotherapy afterwards? Because there was a clear tumor. I mean, I know Nigel would.
You're meant to be my friend.
I mean, the indications were there was a clear target, but recurrent surgery is always, recurrent tumor is always difficult surgically. There was a clear CSF pouch in that area. So likely that complicated.
I would definitely have offered him revision surgery where I'm sitting here today. I mean, 2000, I've been a consultant for 5 years, pretty green. We thought it was in the cavernous sinus, but with an endoscope now, definitely reoperated.
You still need to say who you are and where you're from.
Okay, yes, I'm Karim Miran from Charing Cross. So I do think that surgery has really evolved in the last 20 years, and radiotherapy hasn't. And of course, my feeling is that with your new techniques, you would not have caused the hyperpituitarism that we cause with the radiotherapy, and that's, I think, important. So I would be very keen to have redo surgery now. I mean, if this case happened again, I mean.
I hear you.
There's a question online here saying, what about pasireotide for bulk reduction?
I might ask Rob to, is that okay? Can you answer that one?
So the question again?
The question was, what about pasireotide for bulk reduction? Is that an effective treatment?
I mean, if we're going to use the somatostatin analog, we'd use the first generation first, wouldn't we? So I don't think we'd go straight into pasireotide. And as I mentioned, the risk with diabetes is so high that I tend not to use it as well. So I think there's less than 1 to 2% of tumours which grow on first generation somatostatin analogs. So they're pretty much always going to control the disease. And it doesn't matter if that got any bigger, as long as you've controlled it. So the first generations would have been absolutely fine. So I don't think there's an issue with that.
Quick question. What was the epilepsy? Do you know the type of epilepsy he had? Was it tonic-clonic seizures, focal seizures? I'm just wondering in the context of radiotherapy where any of the fields have hit his medial temporal lobes.
So currently he's not having epilepsy. His treatment was tailed off, but back at the beginning it had been focal. I think it was absence, definitely not a generalized tonic-clonic seizure.
Okay. Was there a question in the audience? I saw a hand kind of going up. Were there any more questions in the audience or no?
Anything on the chat, Corinne?
No, I think we've convinced everybody that we could. Oh, here we go. Ryan Costa's come back.
Why
I suppose it's a comment. Shall I read it out?
Do and then Rob's made a very good point that we could actually answer the questions, couldn't we?
Yes, indeed. So I suppose redo surgery at the time may have been difficult then. Would surgeons be nowadays feel a lot more comfortable considering the evolution of endoscopic surgery, underlines the importance of a good MDT?
I mean, the answer to that is no. I mean, if I've been a microscopic surgeon for 20 years, I would have been happy to go back in endoscope or microscope. The fact is the endoscope is the tool we use now. You could do that microscopically.
But I think you're better at getting the tumour out and leaving behind the pituitary.
I just think that's, having done hundreds.
Yeah.
So how about the questions? And I might ask Rob Murray just to comment on a couple of them, just because this is all aligned to your talk, you see. So what are the possible reasons for discordant growth hormone and IGF-1 in this patient? And you mentioned in your talk about 25% of people have that. What are your thoughts?
With this gentleman, the obvious thing you would look at would probably be the radiation. So when we give radiation, we reduce the peaks, but the baseline in growth hormone goes up. So you end up with more, if you give growth hormone like that, and it's been done in studies of giving growth hormone back to growth hormone deficient individuals, if you give it as a steady state rather than as a pulsatile, you get more IGF-1 generation from steady state growth hormone. So that's what you're getting with radiotherapy. You've now got an increase in baseline, reduction in pulses. So your growth hormone's being delivered in a steady state. So you generate more IGF-1. So after radiotherapy, you've got much more chance of having a high IGF-1 discordance. He's not in remission, is he? Clearly by our numbers. So, but he's someone that, you would probably watch. So I think I would leave his medication and just probably watch this gentleman and treat all his comorbidities and his vascular risk aggressively.
Thank you. And yes, he's over 40 now. So I think I saw him the last time I'd had a chat about starting statins with that lipid profile, actually. And your talk was very good about
We've got time
that.
for one more brief question.
Oh, hi, Emma. Hang on. I've got my flat shoes on.
Thank you. I think it's really difficult about these IGF-1s. I'm fascinated to think about the radiotherapy actually pushing that up. That's a really helpful point for me. But the other thought I had was obviously the radiotherapy's kicked in, but it's interesting his cortisol axis hadn't gone, I don't think. But the cabergoline, we don't know if that's doing anything, do we? I'm just interested to know about that. And whether or not you've considered a trial of, I mean, you've stopped the lanreotide. I don't know whether you ever did a trial of that or not. I always find that one a difficult one too.
Yes, and I saw him last, actually. And in fact, I was tempted with that last set of numbers to the next step, take him off the cabergoline and see if it's making any difference at all, actually, with that day curve, because I wasn't really sure if it was doing anything. That was my next thought too. So thank you.
Okay, so thank you very much. Excellent talk. I'd like to introduce our next speaker. Who's going to talk about surgery as first-line treatment for prolactinoma from Imperial College.
Oh, sorry.
Good morning. My name is Mohammed Saad. I'm one of the endocrinology registrars currently working at St. Mary's Hospital. And thank you for giving me the opportunity to present this case. So starting from the case history, this is about a 28-year-old gentleman who was referred to us by his GP for investigation of an elevated prolactin. This was checked by the GP due to symptoms of low libido and erectile dysfunction. He had background history of major depression with suicidal ideation that required admission under the Mental Health Act 5 years before. During that period, he had received multiple antipsychotic and antidepressant medications, but importantly, he was not taking any of these medications at the time of his referral. So we did some lab results which showed that prolactin was elevated at 13,498 milliunits per liter with a negative macroprolactin. His testosterone, just keep in mind, this is a non-fasting PM sample, but it was slightly low at 9.4 nanomoles per liter. His LH was 2.1 units per liter, while his FSH was 3.5 units per liter. Rest of his pituitary function was normal. We did an MRI pituitary. So we have got coronal T2 weighted image on the left. Thank you to our neuroradiologist, Dr. MLM, for putting out these arrows, which are very helpful in understanding the structures. So we have got a large cellar and supracellar lesion in here, which you can see, which is abutting but not invading the left cavernous sinus in here, and which is not contacting or compressing the optic chiasm. We have got the coronal T1 weighted image after gadolinium in the center, which is showing that the mass is poorly enhancing in here, shown by this arrow. And there is a rim of peripheral enhancing tissue, which is likely representing normal pituitary. There is another image on the right, which is a sagittal T1 weighted image after contrast, which again shows that the mass is poorly enhancing with a rim of peripheral enhancing tissue, which is normal pituitary. So the case was discussed at Imperial Pituitary MDT. There were concerns about the use of dopamine agonists due to patient's psychiatric history, and given the clear surgical target, it was proposed that surgery could remove the tumor and achieve resolution of hyperprolactinemia. At this point, I would present this question to the audience. What treatment would you offer? Would you offer cabergoline? Would you offer testosterone given his symptoms, or would you go for surgery?
That's not, so sorry. Oh my goodness. I'm sorry, criticism. Oh. Where has it gone? I'm so sorry. Oh, that was, no, that's not it. If I can, let me just see if it's somewhere else. Sorry. Here, I'm so sorry.
No, I think that's not our case.
That's not our case. I'm so sorry. This is totally my fault. I'm so sorry. Can I just ask you to maybe pause, because I think we're not on the right. Give me 10 seconds. I'm really sorry about this. Let me just, I'm going to, and then I'm going to stick. I don't actually know where the slide has gone now. No.
Yeah, that's it. That's it. Hit present.
I'm so sorry, everybody.
Here we are. H.
Okay, apologies.
Let's go back to the
Do you want me to pop it back up for you? Sorry. So I'll just give you the biochemistry for a minute, okay, and then you can just have a think about what treatment you wanted to start. Okay, shall we unhide?
Yeah.
Right, so majority in favor of surgery. Thank you. I'll probably just hide this. Right, okay, so we discussed the option with the patient. We gave him the option of cabergoline treatment with frequent monitoring for any psychiatric symptoms, with monitoring of his mood, with psychiatric input, and we offered him the option of surgery, and he chose surgery. So we went ahead with endoscopic transphenodal surgery for removal of his prolactinoma. This is the post-operative MRI. On the left, we have got coronal T2 weighted image. So we have got this area, which is showing some mixed intensity material, which is inconsistent with the post-operative blood products, some fluid and gas, and which is kind of an expected thing after surgery. But importantly, the solid tumor has been resected, as you can see, and there is no evidence of residual disease. There is a coronal T1 weighted image post-contrast on the right, which is showing this resection cavity. And again, there is a thin enhancing rim representing a surgical capsule and normal pituitary tissue. His post-operative prolactin was 243, signifying good post-operative clearance. His histology showed sparse degranulated electrotroph adenoma with a Ki-67 index of 3 to 4%. On further follow-up, unfortunately, the patient's serum prolactin started to rise. So this is 6 months after surgery. His prolactin is 564. His testosterone, again, is non-fasting PM sample, but it's normal 11.2. His LH is a bit low at 1.2, and his FSH is normal at 4.8. His libido remained normal after surgery. It improved actually from his pre-surgical symptoms, but after a few months, patient described that his libido fell off a cliff, and it remained persistently low afterwards, causing relationship difficulties. We did a repeat MRI of the pituitary. This is a coronal T2 weighted image in here, which is showing that this resection cavity, which we could see in the previous image, has collapsed now, but the suprasellar compartment importantly remains clear. On the right is the coronal T1 weighted image, post-contrast, and we can see some small volume lobulated, poorly enhancing tissue here near the left cavernous sinus, which is suspicious for small volume residual or recurrent disease. We did a cannulated prolactin series, which confirmed elevated prolactin with a prolactin of 543, 550, and 498 at 0, 60, and 120 minutes, respectively. Importantly, serum testosterone remained normal throughout after surgery. We had another discussion at our imperial pituitary MDT. This time, the lesion was not thought to be a clear surgical target, and further surgery was thought unlikely to be curative. Concerns remained about cabergoline treatment given his previous psychiatric history. We had this option of gamma knife, which was proposed. Afterwards, there was discussion at gamma knife MDT, and it was agreed that he would be a suitable candidate for gamma knife treatment. However, the patient and his family were concerned about hypopituitarism as a consequence of this treatment, so they chose to reconsider other treatment options. So we had a look at his testosterone levels, which were consistently normal, but the patient was very keen for testosterone replacement. He was taking tadalafil, which helped enable normal erections, but he still did not have interest in sex. He was referred to a sexual dysfunction clinic and was also seeing a psychosexual therapist, which did not help much. He was started on a low dose of topical testosterone, but his libido remained poor. He was also referred to psychiatry and commenced on metazapine for depression. He was reviewed in another center near his family home, and he was actually started on low dose of cabergoline at 0.25 milligrams weekly several weeks ago with close monitoring for side effects, and so far he has been well. So, I would conclude the case and leave these questions for discussion for the audience. Number one, what monitoring is needed for cabergoline treatment given his previous psychiatric history? Number two, would the audience recommend continuing cabergoline or offering MRI treatment? And number three, should testosterone replacement be offered in such situations? Thank you for your patient listening.
Thank you very much for a great and clear talk. Who would like to answer the questions? Anyone? I think the first thing to say about the, Emma, sorry. I was going to make a quick comment about cabergoline. I think medically legally, what's clearly important is telling the patient and documenting about the potential side effects and the psychiatric possibilities.
I think it's thanks for that great case. I think starting cabergoline with someone with a psychiatric history is always a bit challenging, but we have had experience of it, and I think it's case by case. So really close liaison is what I would say. And if you need to see the patient every couple of weeks, do so, but don't cross your fingers and hope. I've certainly had one patient with very long-standing anxiety and depression whose symptoms changed not one iota and had active counselling and therapies during his treatment. He's still tolerating cabergoline well, but I think for every patient like that, there may be a patient that you wouldn't even feel it was safe to start. That's just my personal view. I'm not sure about the gamma knife really. I think the issue around his sexual function, I mean, he had a normal testosterone throughout, so that's got big red flashing warning lights that actually we're not going to be able to address that. And he actually was helped with his erectile dysfunction with sildenafil, I think. So I think that was a different challenge, and I can understand the pressures to start testosterone, but I'm not sure it was indicated and it didn't make a difference. So that, but again, other factors may influence that, so that's very tricky. So I think everything was done in terms of offering other supportive therapies, which is very sensible.
Thank you.
Is there anything on the chat that you want to read out? Oh,
Ramesh,
sorry.
Thank you. So the question was whether you can use surgery as a first-line treatment for elective cases when there is a concern about psychiatric complications, or also when you use surgery as a primary treatment when you have a side effect or a patient is not really tolerating it and resistant to cabergoline. But is there another indication, like if you have a very clear target, like a very defined microadenoma or a well-defined mesoadenoma, even a macroadenoma, which you think you can resect completely without a significant risk to the pituitary gland? I think in selected cases, there is an indication for that as well. We know that we use medical treatment. We prefer medical treatment as surgeons for massive tumors invading the cavernous sinus and other cranial fossa. But I wonder about using surgery as a first-line treatment for some cases. What do you think? Is this a question for the endocrinologist?
There's just a couple of comments on the chat that I can just go through. So there's quite a wide range of views. One is no indication for cabergoline or testosterone treatment. Dysfunction of sex is unlikely to be related to testosterone and hence not provide testosterone. Okay, and the alternative option is we should try low-dose cabergoline. It is clearly an MDT decision, which is really important. And if the psychiatrists are going to monitor him, then we can give it a try. It's a summary of a couple of the comments.
Maybe I might just ask Rob as an endocrinologist, what is your experience of, I mean, Emma's Hatfield from Charing Cross has given us a nice summary of some of the challenges we've had. Have you had anything similar in terms of surgery or surgery for practice owners where you've had some concerns about cabergoline and side effects?
Yeah, I mean, we certainly see more of the psychiatric side effects, and people have a baseline of psychiatric or mental health disease to start with. So we are thinking this chap's definitely more at risk. We've had a few people who said they've developed symptoms, which impulse disorders, etc. And it's always difficult actually in these individuals to know if it was preceding, because we don't ask them at the beginning, are you in debt? What's your sex life like? Are you already overeating? Do you gamble? So it's quite difficult to know if it's new or it's the drug. And we always blame the drug. So we have sent a few, and I was saying earlier when we was talking about the patients I've sent to Nick Phillips, our surgeon, and saying it's actually the more difficult ones, and it is the people who've got the psychiatric history who then feel it's got worse. And so I'm sending all these patients to Nick, which are quite difficult. And so I think he'll never operate on another prolactinoma for me, because I really do send him the cases which are a little more trouble to him. It's not the normal. The data in the microprolactinomas looks brilliant for surgery. So I think that's something that might come. And we cure a lot of those. There's a high rate of relapse in the macroadenomas. With your chap, I don't think I would have put him on cabergoline because I'm not sure what we were trying to make better. As in the comments there, because it's sexual dysfunction.
One of my colleagues' cases ended up in prison under the Mental Health Act several years after the shared care decision to use cabergoline. Mental health issues can be triggered several years later, and it's extremely difficult to know if it's cabergoline or the underlying mental health disease.
Yeah, it's a very good point to end on, isn't it? Yeah. Thank you.
Thank you very much.
Thank you.
So if we invite our third speaker, yes, thank you. Dr. Hack from the Royal Surrey is going to present a case on protein beam therapy in germinoma.
Good morning, everyone. My name's Ikra. I'm one of the F2s from Royal Surrey County Hospital. Went to medical school in Imperial, so it's very nice to be back. So my case today is about a gentleman who came to us circa 2019. He had a germinoma, received proton beam therapy, and we'll look at his journey from when he was diagnosed to after he was treated, and look specifically at his endocrine function. So to outline the case, okay. So he's a 19-year-old, previously fit and well gap year student, initially presented to his GP practice with about 6 weeks of polydipsia, reported drinking about 5 to 6 liters a day, associated with urinary frequency throughout the night, and quite a bit of fatigue and headaches. No significant family history of diabetes. In terms of oncological background, sister had a platal tumor, father testicular tumor. Interestingly, he spent about 4 weeks in South America at high altitudes hiking, returned shortly afterwards where he noticed that the symptoms persisted. On examination, he had a normal examination and BMs of 4.6. So he returns back to his GP, GP initially thinking that it's to do with an altitude adjustment. He's finding that his mouth is dry, very difficult to swallow, and still drinking about 5 to 6 liters per night. GP refers him to Royal Surrey Hospital, and he has some labs done overnight. So his labs show an increased serum osmolality in view of a reduced urine osmolality, pointing towards a diabetes insipidus picture, a high prolactin, a very low testosterone, which was repeated in the morning in view of a normal LH and FSH, and high TSH in view of a normal T4. So he's discharged with an outpatient emergency MRI and a follow-up with the Cedar Centre, which is our centre at Royal Surrey for endocrinology and diabetes. When he's followed up with Cedar Centre, he started hormone replacement therapy, so cabergoline, thyroxine, hydrocortisone, desmopressin, and then later on Testogel and then Nebido. His emergency MRI shows 17 millimeter pineal region mass with some slight thickening of the infundibulum and not visualized here, but some spread to the frontal lateral horns. In terms of confirming the diagnosis, he has a CSF done, which shows beta HCG and alpha fetoprotein tumor markers that are actually within normal range. Later on, goes for a craniotomy and biopsy, which confirms it as a dysgerminoma, and that's the histology report shown there. In terms of talking about germinoma as an overview, so it's actually quite a rare primary CNS tumor. It occurs in 0.2 to 1.7% of primary CNS tumors. It occurs more frequently in males, it's 13 to 1, and most of them are diagnosed under 20 years old. Diagnosis involves the clinical presentation. Over 90% will actually present with diabetes insipidus. Many will present with features of hypopituitarism, and it's often confirmed on an MRI with a pineal region mass that appears in over 50% of cases. Tumor markers, interestingly, can be positive or can be negative, like in our case, and it's often confirmed if the tumor markers are negative with a surgical craniotomy and biopsy. In terms of treatment, it's twofold. So we're looking at the endocrine function of the patient, and that often involves the replacement therapy with desmopressin if it's diabetes insipidus, and if there's features of hypopituitarism, looking at the hormone replacement therapy as well. And then in terms of the tumor itself, looking at radiotherapy, and that's often proton beam therapy, which we'll come to in a little bit, plus or minus chemotherapy. So this is a nice schematic outlined by the NHS of the clinical pathway that often patients follow following a pineal tumor region mass on the MRI. So often first line they'll have some tumor markers done, which can be negative or positive. In our case, it was negative. They'll then go on for a craniotomy and biopsy, which confirms the tumor itself. And then most will be referred on for craniospinal irradiation plus or minus chemotherapy. So proton beam therapy versus conventional radiotherapy, this is quite interesting for myself to read about in terms of the differences. So proton beam therapy is a different form of therapy which offers a high dose of radiation to the tumor itself and offers a lower dose of radiation to the healthy surrounding tissues. So it offers a dosimetric advantage. And this is a nice schematic in a study that was done, which highlights the differences between the radiation dose that is going to the tumor itself and then the surrounding tissues. So the bits in red are the high radiation doses, bits in green are obviously the lower radiation doses, top images are for conventional radiotherapy, and then C and D are for proton beam therapy. And as you can see, the proton beam therapy, there's almost little to no radiation in the surrounding tissues here, with a lower radiation dose in the craniospinal axis. So we know that it offers a dosimetric advantage, and we know that it sort of targets the tumor head on. But the question really is that if there is a lower radiation dose to healthy surrounding tissues, could it mean that proton beam therapy is more clinically effective? And at the moment, the literature review is sparse, given the fact that it's a relatively recently commissioned therapy. There's still some scope to understand whether or not there are better outcomes in terms of the neurocognitive side of things, but also from an endocrine perspective. So often with radiotherapy, you'll see a hypopituitarism that is secondary to the radiation. So if we go back to our case, our patient got approved for funding for proton beam therapy in Germany. He received 24 units to the CSI axis, followed by 16 units to the tumor. And his labs were redone at the Cedar Center a year later. And as we can see, the prolactin has come down, testosterone has come up quite nicely, and his TSH is moving towards a normal range. And at this point, we decided to wean him off the hydrocortisone, testosterone, and levothyroxine. He was still on the DDA-VP at this moment in time. At 3-year follow-up, we actually see off of all hormone replacement therapy, his prolactins come back within range. His testosterones come up even more. His LH and FSH are also within range, and his TSH is now within normal range as well. Clinically, he was a different person. He came to clinic and he had just graduated actually from Imperial with a first, so did very well. He recently got married as well, and a follow-up MRI, which I don't have the images of, didn't show any recurrence either. So he did quite well following on from the radiation therapy. So questions for the audience. Do we still expect our patient to develop hypopituitarism? Can proton beam therapy offer long-term endocrine recovery for patients? And is our patient's testosterone recovery a result of proton beam therapy or a result of the cabergoline and prolactin effect?
Thank you very much. An excellent presentation, quite a rare case. Any thoughts from the audience or anyone who's had similar patients with germinoma or experience with protein beam therapy? No? And can I ask, do we not offer this in the UK? Why did he have to go to Germany?
Good question. And I'm not sure. I think Dr. Blitzko either.
So all his germinoma treatment was at Marsden, and Marsden referred him there. It's just at the time there was no other place, so it was fully funded by NHS, and that's where he had it done.
Okay. And now do we have it in the UK, or do people? We do.
Yeah. There are some centers. I'm not a proton beam specialist, but there are some centers. I think UCH and Manchester. Oh, yeah, Manchester. Yeah.
Was he ever actually considered for surgical excision of his germinoma, his pineal lesion?
Yes. So
it's Marsden. I don't think the surgery. No, I think the radiotherapy is first line treatment.
That's controversial. I mean, I think one of the issues, pineal tumours are very rare, and certainly within our Society of Neurosurgeons, there's a.
He also had a few lesions that they showed like metastasis. So I don't
okay.
Frontal horns, yeah.
And also, I think the tumor markers were clearly positive.
In his case, they were negative. Yeah, they were within normal range.
But he had a few nodules around that.
Yeah, okay. I mean, just a basic principle about pineal tumour surgery. Obviously, it is much more difficult. It's technical surgery. It's difficult to do. And we're now discussing within our society as to whether this type of surgery should only be done with a handful of units in the UK, because they're so rare. We're talking about less than 5 cases per year being operated surgically. But you could be very careful about making decisions not to operate because you can't, and surgery actually may be the better treatment.
Is there anything on the chat?
And do we know anything about, because he's still very young, about long-term prognosis, about risk of recurrence?
From what I understand about pineal tumours, the cure rate is quite high, so they're quite radiosensitive, and I think that's why they go for radiation as a first-line treatment. It's about 85%. Recurrence is about 20 to 50%, if I'm not mistaken. So his prognosis looks good.
Okay.
Germinoma
has quite good prognosis from what we read. But it's very interesting because he's a really, really free spirit, amazing guy. He's actually helping us. He graduated in engineering from Imperial, and he's doing a project with us. He's helping us to develop some.
You can't hear.
Sorry. Yeah. We'll just wait. Anyway, yeah. So Dr. Agnesh is saying that he's actually helping, I believe, with the diabetic foot team at the Royal Surrey now. So
I might cheekily, poor Rob Murray's never going to come again now because I keep asking all these questions, but he's got to sing for his supper at the end of the day. So I was Googling proton beam therapy last night to try and educate myself before this, and I realised that Rob had written a nice review this year on proton beam therapy. What are the chances? So I might just ask him.
Before you do that, there's a question here saying, how does proton beam compare with gamma knife?
Yeah, so gamma knife is still photons. So we're still using X-rays. It's just single shot, highly focused radiotherapy using a cobalt source, which has 200-ish separate beams, which aim at the same time in a single shot at your lesion. Because it's so highly focused, your tumor needs to be small. So once it gets above about 2 centimeters, you can't give it because the edges of your tumor won't get enough radiation dose. So stereotactic is photons. It's the same as conformal radiotherapy, VMAT, IMAT, etc., using photons. So basically light beams. Proton is mass particles. So we're actually sending mass particles into the brain. It's different. If you use photons, the energy levels of photons drops as soon as you shoot them. So they get less and less energy the further they get. And they go through your tumor, which is what you saw on your images, and why you saw more the green, the other side of the spine, because you'll shoot it and the energy will still go and it will shoot through your thing. Protons are different. They have something called a Bragg effect. So their energy levels fall, they continue to be the same, then suddenly there's a Bragg peak and the energy levels fall off when you hit the tumor. So what you need to do is get that Bragg effect at the point of where your tumor is. And then all the energy is released and you don't get an exit beam. And that's why it's a lot better. And you saw in your spinal stuff, there was nothing under the spine or the abdomen, was because that if you get the Bragg peak in the spine, no radiation goes any further. And it's mass particles. That's one of my worries, is it's mass particles we're sending rather than light. And therefore the tissues before you hit your tumor is what worries me in the future. We also need to get the Bragg peak right. We've had a couple of people in the studies of pituitary tumors which have shown brainstem vasculopathies, because they probably got the peak wrong, and they've aimed it a little bit too far past the pituitary and it's hit the brainstem. So that's been an issue at the minute. So that'll just be experience with proton. So I suspect there'll be more and more studies in pituitaries doing it. I assume your patient probably had a bicentric lesion, because otherwise I can't see why they would have had DI if it was in the pineal. So a good proportion of these are bicentric and they have a second lesion just above at the hypothalamus. So I'm assuming that's why they had DI. It's going to be no different. If you give 40 gray of radiotherapy to the pituitary as proton or as photons, your outcome is going to be the same. That doesn't matter how you're delivering 40 gray. You've got 40 gray of radiation, it's the same. And therefore, that's not going to matter. The difference is the exit beam. The difference is that you can aim similar to stereotactic at a very small area, and the drop-off's very rapid, so you don't get the scatter. So like now, we're seeing scattered light. You don't get scatter with proton. It just stops.
Just quickly, so on that comparison that you showed us with the red, the different colors and the red radiation, that's with conventional then, not with stereo, or with
conformal,
as conformal.
Conformal, yeah.
The proton was the bottom panel, I think,
Yeah,
wasn't
the
it?
proton.
Yes.
And proton beam therapy with CND. Yeah.
Okay, but gamma knife would give you the same benefit.
So gamma knife you couldn't use because it's a big area, because you're highly focused, single, small, less than 2 centimeters. So with this, you can see, because on the bottom one with the proton, it's all gray, because you've got the Bragg effect has been hit in that red area, and therefore there's no energy left. It's all absorbed within the red. There's no exit beam. Whereas where you shot it in the top, it's gone through the red area which you've been aiming at, and then it's gone into the tissues below, because you can't stop photons. They'll have less energy the further they get, which is why it's green and not red, but you can't stop them, so you will get exposure.
Thank you, that was great. I understood a lot more at the end of that. Thank you, Rob.
Just say before we move on, can I make a plea that we all try and avoid the word diabetes in diabetes insipidus and change to vasopressin insufficiency?
It's
Okay.
vasopressin deficiency.
Or
Is
deficiency.
But I will say that in fairness, listen, there's lots of cases coming up where we've made that clarity. And look, you've done super well. You're an F2, which is an astonishing achievement to come and present this. So we'll all get there in the end. It's a sea change, isn't it? Learning a new name for something. Well done.
Thank you very much. Thank you.
So I'd like to introduce the next speaker, Dr. Cugnago from Lincolnshire and Calabria in Italy, team, to talk about primary amenorrhea, a clinical quandary.
Okay, so I'm an SHO from Boston and Lincolnshire. which is a DGH. And this is a case of a primary amenorrhea, which was referred to adult endocrinology from pediatrics. Okay, yeah. So it's a 17-year-old girl who'd been had a complex medical history, and she'd been seen since birth by various different specialties. She's known to gynecology, known to pediatrics. She'd been seen by clinical genetics, and the reason for presentation was amenorrhea and delayed puberty. So since birth, she was known to have intrauterine growth restriction, for which she was small for gestational age. She was short in stature, and she always followed the 0.4th centile for height. Looking back through the notes, there's no documented reason for the intrauterine growth restriction. And interestingly, she was born with some structural abnormalities of the hands and feet. So I was able to find these images. So this was you can see on the left hand, she has fusion of the third and fourth fingers, and she has some hyperplasia of the distal phalanges on both sides. And looking at the feet as well, she's got the soft tissues of the first and second feet are both fused, and the bones on the third and fourth toes as well. So for some reason at birth, based on this short stature, hyperplasia and syndactyly of the digits, she was investigated for this septoptic dysplasia. I'm not sure why. I think it was maybe a bit of a jump, but in any case, what it shows is completely normal neuroimaging. And this was the report that I found. Okay. So in terms of the family history of the patient, her great aunt also had syndactyly. Her father had type 1 Brugada syndrome, and at age 40 had a cardiac arrest and ICD implanted. She has a younger sister with type 1 diabetes, diagnosed at 10. And she was referred to clinical genetics. She had karyotyping. She was found to be normal female. She was investigated for Brugada syndrome, and on echocardiography, she had normal heart and normal ECG. With regards to her hands out of interest, they decided to do nothing and let her decide when she was older. And this was her when she's a bit older. And in terms of, she had dental assessments, found to have some kind of malocclusion. So she was referred to adult endocrinology after she'd been seen by pediatrics. They found her to be in primary amenorrhea. She was stage 3 for breast and pubic hair development. They said that she'd begun to have thelachy at the right age, but she didn't progress in the breast development. And she had no family history of constitutional delay of puberty, and we already knew that she was a normal female chromosomally. So gynecology requested a ultrasound scan to assess the anatomy. They couldn't find the uterus very confidently. They could see a small uterus, and they struggled to find the ovaries as well. And when we did the MRI, we found that the patient had a very small uterus, a very small ovaries, and they concluded that the patient has atrophic ovaries and uterus. And in terms of the kidneys, there was no, the kidneys were normal. I included an image just so you can see very small uterus there. Okay, so the patient was referred to adult endocrine, and on assessment, she was generally well, normal, no cognitive delay. She was performing very well in her GCSEs. She looked to be small, looked younger than her age. There was no clinical evidence of any signs or symptoms of endocrine disorder. She was normotensive, and she was normal BMI. So we did a full panel of the hormones, and we can see that the FSH and LH were both low, and the estrogen was also low. So we concluded that it's a hypogonadotrophic hypogonadism. We requested the MRI pituitary to assess for pituitary lesion, and they found a well-defined nodular lesion, which was 1 centimeter by 5 centimeter and 0.5 centimeter. And they considered at that time that this most likely represented a pituitary adenoma with the hemorrhagic component. And the patient did not have any symptoms of headache or apoplexic symptoms or anything. They decided to do a follow-up MRI after 3 months, and it showed unchanged appearance. This time, the radiologist mentioned that this could be a Rathke's cleft cyst, which did not have any supracellular component, and did not affect the optic chiasma, etc. I included the image, which I don't think is very helpful, but anyway, yeah. So the patient was referred to the local pituitary MDT, where it was reviewed by radiologists with more expertise in pituitary. They concluded that this was most likely representative of Rathke's cleft cyst, and they decided to refer the patient to special adolescent gynecology clinic, which is the what we have available in our area. And they think that the patient will not likely need hormone replacement for this ovarian failure. And they referred the patient to counseling as well because of the psychological consequences, and they're suggested to have repeat imaging, but they did not really come to a conclusion about what is the etiology in this case. So I included some images just for those that maybe not aware. So the Rathke's cyst is a remnant of the Rathke's pouch, which is formed when the ectoderm forms this pituitary and can later in life present as a fluid-filled cyst. And it is very common in about 2 to 26% of autopsies. They find this cyst, but it's usually asymptomatic. But it can, in some cases, present with hypopituitary symptoms. So these are different kinds of cysts that we can have. In our case, we have a intracellular cyst. So in summary, it's a case that didn't have a real clear conclusion. Maybe we'll do after today, after we pull all these brains together. But it's a 17-year-old girl who was presented to endocrinology with delayed puberty, primary amenorrhea, with a complex past medical history, intrauterine growth restrictions, syndactyly, family history of various different things for which people were considering, could this be some kind of genetic component to it? Anatomically, she has atrophic uterus and ovaries, and she has this hypogonadotrophic hypogonadism picture, and an MRI pituitary, which shows a intracellular Rathke's cyst. So first of all, in this case, it was very important that the patient was referred to the local pituitary MDT because these kind of cases are not familiar to the radiologists in our hospital, and for the adult endocrinologist as well. And the patient in this case required many different specialty input. The point for discussion in this case really is what is the etiology of this FSH-LH insufficiency? Is the Rathke's cyst just incidental finding, and the possibility of genetic syndrome, for which we had a few suggestions, but I'll leave that to the audience first of all.
Lovely, thank you very much. That was a really fascinating case, and
I have a question. Did your patient have loss of smell or?
Yeah, absolutely. So I think you're talking about the common syndrome. No, the patient was not anosmic. She was normal. But in terms of this syndrome, she does have the skeletal dysplasia. Yeah.
And the second, sorry, I noticed that you'd done some genetics.
Yeah.
Are these the only genes that were tested for?
So yeah, absolutely. The patient had karyotyping, but the patient has not had full investigation of these different syndromes. Possibly she will get that after she's referred to the specialist clinic, but yeah.
I think Emma wants to go through the imaging.
Yes.
Yeah.
Poor Emma, I've just grabbed her, but she's here from neuroradiology. This is Emma Lim. So I wondered if you wanted to bring up your slides again for the imaging, just because I always like to be educated. Sorry, Emma, now to put you on the spot.
Then you're
one of the actual.
This one? Okay.
Thanks. Do I need to press anything? No, I can use this up. Okay, yep, so radiologically this looks like a classic Rathke cleft cyst. And sorry, I don't have a pointer, but for those in the room, you can see on the sagittal T1 weighted image, you can see the adenohypophysis here anteriorly and the normal posterior pituitary bright spot posteriorly. And we have a classic location of a Rathke cleft cyst between the anterior and posterior lobes, which is T1 hyperintense, slightly less hyperintense than the posterior pituitary gland, which is a normal finding. They're often T1 hyperintense and maybe T2 hypointense, but they don't have to be. So this is a very classic location that would be consistent with a Rathke cleft cyst. And we can also confirm on the axial imaging, so I'm not tall enough to reach it, but it'd be directly anterior to the posterior lobe. So yeah, there are no particular features that this would be a hemorrhagic microadenoma.
Thank you, that was super helpful. Thank you, Emma.
So one of the questions was, is the Rathke cyst in any way responsible? And I think the answer is no.
Yeah.
This may be a bit unfair, but to demonstrate my medical school teaching at Charing Cross, it's the Mullerian duct, isn't it, that forms the ovaries and uterus. So has she had, presumably it must be genetic, and for some reason she's got a hyperplastic, agenetic reproductive system, along with other genetic abnormalities, which I can't fit in with her hands, but that hypogenesis of the ovaries, uterus, all point to a failure of Mullerian duct development, doesn't it?
Yeah, I mean, I think it was tested for anti-Mullerian, and that was also negative.
So there is
yeah.
So what's the test? I mean, that's fascinating.
I can't remember. I just it was prepped before. Yeah. Is it the hormone? Yeah.
Do you know if there are any other genetic syndromes that are associated with, presumably what's very rare, with small ovaries, small uterus? Anything else? Does anyone else know what other genetic abnormalities go hand in hand with it?
Cowman's does. I think Cowman's is associated.
So yeah,
with
Cowman's was the one that we were, I think, thinking about. So like you said, you mentioned the anosmia, which is negative. I think that this is probably where this case will go.
Can I ask a question about the HRT? So this young girl's got hypog and has a very small uterus. Are you starting her on some small low dose estrogen?
So this is just really just discussion, because this case only went to the MDT last week. So we won't start her on anything.
You'll wait for the MDT.
This one will go to the specialist adolescent clinic.
Okay.
I think this will be,
Okay, yep.
This is a couple of things on the chat here. So Anna Crown from Brighton thinks the pituitary thinks an incidentaloma.
Yeah.
And we definitely get on with Eastern therapy, which are guideline driven. And also there is now a panel, she says, for hypog panel. You can just request it directly for genetics.
Panel, you mean? Okay, that's very wise actually, because yes, we need to be a bit more switched on about those panels, don't we? For
then
genetics.
There's a question about a GnRH test. GnRH, is she GnRH deficient?
Yep, would you do a GnRH test?
The patient has not had GnRH testing so far.
Okay,
yeah.
Thank you. Any questions from the room? Any similar cases or experience?
Could I just ask, I don't know if anyone's got any thoughts, could some of the, I'm so sorry because I was in and out, so I missed a critical bit, but could some of that hypoplasia of the uterus be just chronic estrogen deficiency rather than syndromic? Could it be that we do sometimes see that, don't we? We have a very immature looking
yeah, agree.
I'm sorry.
Yeah, agree,
Just,
agree.
you know, you can have a very immature looking reproductive system, can't you? Because she's never seen estrogen. And actually, if you start to give her low dose estrogen, that might change, mightn't it? You could still be correct, Nigel, I don't know. But I wondered about a GnRH test as well, because we don't do them often. But I wondered if there was some endocrine relevance to this, actually. I'm going to look at Robert Murray again, sorry. What's your thoughts about that?
I generally don't do GnRH tests for anything. The pediatric endocrinologists still do them. I'm not convinced how helpful they are. I mean, we've got a lady who's got hypog. The panel has 13 genes. I think they test now for Kalman's, some of which have anosmia, some of them don't. And a lot of them are associated with other midline abnormalities, which the patient hasn't got. But yeah, I suspect I'd probably start a bit of estrogen induction myself. I wouldn't wait on the pediatricians to get on with it. Send off the panel, but I don't know what the unifying diagnosis is. I think her uterus and ovaries were so small, I'm not sure it was just the estrogen, but yeah, helping you out. But I'm not, yeah, but interesting.
Are there any other questions from the floor or on the chat?
Just a comment, really. Excellent case and well presented. Important to get psychological support for this patient, and well done for addressing that.
Thank you. Great, thank you very much. So that just leaves me to thank Dr. Murray for coming to talk to us and all our speakers today for really excellent cases and great discussion. So it's time for a coffee break on time.
It is, thank you very much. So if you're remote, please feel free to make yourself a coffee. And if you're here, please go downstairs and don't lift the lid off the urn, is all my plea. Thank you.